be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
Good afternoon, everyone. Welcome to the Lung Cancer Living Room. We're so happy to have all of you with us from wherever you are in the country or the world. Tonight or this afternoon, we're going to be talking about how lung cancer is not taking a back seat during these unprecedented times, and neither are we. Care must go on. And here to talk with us about how care is going on in these uncharted or during these times of, uncertainty and, like I said, unprecedented times is Dr. David Gandara, whom I'm sure you all have seen on previous living rooms. He is no stranger to this program, and we are thrilled to have him here with us today. Dr. Gandara is a professor of medicine, Emeritus, Director of Thoracic Oncology, Senior Advisor to the Director at UC Davis Comprehensive Cancer Center. He's a medical oncologist and researcher and has been working in lung cancer for a very, very, very long time. So we're thrilled to have him with us today.
Well, thank you, Danielle. It's a pleasure to be with you again. I'm happy to meet with you today and to talk about some of the changes that have come about and some of the things that have not changed. Now, COVID is with us.
Lung cancer patients, as you well know, have expressed concerns about delays in treatment and care, especially during, these last couple, 2-3 months. There are also challenges that some of them are having with second opinion appointments being canceled or delayed. How has treatment changed in the time of COVID-19? What should and should not be delayed? And what role is telemedicine playing from your perspective in the academic setting?
Maybe I'll start with the question that many patients are quite interested in, and that's in the time of COVID, should my treatments be delayed? Should they be changed? Or should things go on exactly the way they would have? The answer to that is it depends on where that oncologist, where they practice in the world. So not only within the United States, but within the world. All of you know how different this disease is, how the incidence and the severity is quite different from place to place around the world, some in Europe, some in Asia, and even within the United States, where in the New York, Boston, Connecticut area, it's been devastating. So with that being said, in California, we have been both fortunate and I think maybe proactive. We have a relatively flat curve at UC Davis. On the East Coast, I saw for the first time today the curve for one of the major medical centers in New York City. And for the first time in 6 weeks, it has begun to flatten. So the reason I give this sort of introduction is if a patient is, let's say, in New York City, they have just had their diagnosis of lung cancer and it's an early stage and they're waiting for surgery. many of those institutions have simply not been able to do those sorts of surgeries because every bed in the hospital was full of COVID patients, every bed in the intensive care unit, in the recovery room, and the hallway were full of COVID patients, many of whom were very ill. Then the issue is, well, do you bring in a healthy patient with stage 1 lung cancer to do surgery and then expose them? So it's not an easy question to answer. But I can tell you what patients think. Patients uniformly have told me that while COVID may kill me, my cancer will kill me if it's not treated appropriately. We know from many studies, for example, that the surgical kind of patient that I was talking about, if we delay surgery more than 6, 8, 12 weeks, that the prognosis is worse because that gives more time for the cancer to have spread to other areas, even if you can't see it on a scan, as PET scan or CT scan, micrometastases. I did a social media poll. So I said, now that COVID has hit us, would you delay chemotherapy or immunotherapy or both in a patient with stage 4 non-small cell lung cancer? And I had 357 oncologists and other caregivers respond. 70% of the people said, no, I would not delay either one, assuming I could still give it within my system. And the remainder, that other 30%, some of them said, oh, I would delay immunotherapy, but not chemotherapy. Some of the others said I would delay chemotherapy, but not immunotherapy, like 5 or 8%. And a few said I would delay both. I would hold them. But the majority, no matter where they were in the world, said, no, I need to treat the patient like I would have ordinarily. And patients chimed in on this. And as I said, they said, don't withhold that treatment from me. So at UC Davis, we've been very fortunate in that we have not had to delay patients' treatments. And we'll talk about later, we also have not had to shut down our clinical trial program, which is incredibly important in terms of bringing new treatments to patients.
I think that's a really very relevant point. It depends on sort of where you are in the system, where you are in the country, how far down the line you are in the learning, right? Because this is, this is a new space for everyone. There's so much that we don't know. We're sort of trying to learn and fly the plane while as we're building it, right, in this area. And I know a lot of patients, and a question has come in around data from the AACR that showed lung cancer patients may have worse outcomes should they develop COVID. But to your point, there's a maybe factor still to that question when it comes to COVID versus a more definitive answer when it comes to just not treating your lung cancer. That's kind of what I hear you saying.
Yes, that's correct. And of course, we can't prevent an individual from being exposed to COVID out in the community. But we can, once they enter our system, we can test and we can make sure that everything is absolutely as safe as possible. And I think throughout the United States now and most other countries, people have figured out how to do this, just like you figured out how to order e-groceries. So all of these things have changed the way we're living. It may not be necessary for the long run, but some of the things I think are going to stick. And a lot of them have to do with patient care. And it's because it's made things better.
You talked a little bit about how, at a high level, about how some to some degree it's been business as usual. And I know a lot of patients watching right now. The screening conversation isn't necessarily relevant because they're already living with lung cancer, right? But I always like to bring it up during meetings like this to remind patients out there living with lung cancer that they are primed for having the screening conversation with loved ones and family members that that they know that might qualify. How has screening been affected at UC Davis?
Well, we don't have a huge screening program, but we have an active screening program. To my knowledge, there has been some reduction in the amount of people being screened. And I think it's valid that this is not a patient with a nodule that we already know about who's being worked up for that. Those workups have gone on without much change. But in a patient who just comes into their primary care physician, and let's say they're new with this physician, and they say, I smoked for 30 years. I smoked a pack of cigarettes per day, and I quit 15 years ago. I'd like to be screened. I think the patient and the physician can make a joint decision that let's give this 6 weeks or 2 months if needed and see what the situation is before you get screened. So it's a different sort of situation from a patient where the physician says, "We already screened you. We found a nodule that could be cancer, and are you willing to go ahead and get worked up for that?" Which might mean a bronchoscopy or a biopsy, scans, etc. Or do you want to wait? That primary care physician would also say, our radiologist or our pulmonologist, whoever has that expertise, has said that your nodule that was found, this is just an example, is high risk for cancer, or it's low risk. In other words, you do have a nodule, but I think everybody who looked at this scan, and this is where virtual tumor boards come in, they all agreed that the likelihood is that this is some benign process. It's an old, what we call granuloma from some exposure you had when you were young. It's not likely to be lung cancer. On the other hand, the next patient, maybe the physician says, your nodule, it looks very early stage, but it looked like it is likely to be cancer. And in that patient, of course, you would advise the patient to go ahead and get the evaluation done.
One of the things I love about you explaining this to our patient community is these are conversations they can then go back and have with their physicians. That's just a little side note that I want the community to know, that this shared decision making process and these conversations with your healthcare team are so important in determining your care, your treatment path, but also in making you feel better in your understanding about the whys behind some of these decisions are being made.
My advice is if you don't ask the question, you won't get an answer. So, for many physicians, particularly those that are quite busy, they have a way of approaching things. And they may say, here's my advice to you. But if you say, you as the patient, if you say, I want to know the pros and cons, I want to know the risk and benefits about whatever the question is, whether it's, should I get this kind of treatment? Should I get a workup? How long should I delay? Most physicians will then say, okay, this is a patient who wants that sort of interaction, who wants to be part of the decision process. Now, you may say that should be every patient, but again, that's not necessarily how everybody approaches it.
That's a really great point, because you're right. Some patients are just like, no, I want you to tell me what to do. I don't want to know. I don't want any information. Just point me in the right direction. So that's also a very real thing. So I want to run into some diagnostics in this time. We talked a little bit about screening, delays versus somebody we already know has a diagnosis. Are you more likely in these times, or is this also dependent on the patient, to do a bronchoscopy, as you said, and go for a solid tumor biopsy, or are you using liquid biopsies more often these days, just to sort of mitigate risks?
Well, that's another question where there's no simple answer. I guess there aren't too many in lung cancer where there are simple answers, but I think that depends on the situation where you are as a patient. And I mean, what your location is. In some institutions, let's say one of those big East Coast institutions that I was talking about, which has had a horrible problem with COVID, all of their pulmonary physicians which would do the bronchoscopy, are all in the ICU trying to help with COVID patients. Do you see what I'm saying? So they may be less available. On the other hand, a radiologist in that institution may still be able to do an interventional biopsy, a CT-guided biopsy. So it depends on the situation. At UC Davis, we've been very fortunate in that we have some pulmonary physicians who are really dedicated to lung cancer, and they've been able to work with us. And when we've needed biopsies, we've been able to get them done within the same amount of time we usually do. It doesn't mean we aren't using liquid biopsy more. We are. And in fact, later this year, we will have a workshop sponsored by ISLC, our International Association for the Study of Lung Cancer, in September on this very subject, the 2-day workshop, so that we can bring all physicians and interested parties up to date on when would we substitute a blood test for a biopsy. We obviously need a biopsy of lung cancer. In other words, we can't make that determination typically from blood. But when do you rebiopsy versus doing a blood circulating tumor DNA? More and more, we have situations in lung cancer where the answer is blood first.
Medical oncology. Some things have changed from coverage, around CMS and at-home infusions for those where that might be an option. What does the patient experience look like right now between an infusion patient versus a targeted therapy patient?
COVID is so bad, but there is a lot of good which is coming out of the situation where things are being made easier and better for both patients and physicians that I don't think are going to go away after COVID calms down. And one of those is the acceptance by insurers like CMS, Medicare, to allow reimbursement for video visits. And I had a clinic a couple of days ago, or late last week, where every single one of my patients, including new patients, were with video visits. So when we engage in a video visit, it's scheduled ahead of time. You do it from your iPhone, although you can do it from an iPad. And the patient logs in, I log in, I can see the patient can see me, and I conduct my interview just the way I would if I was face-to-face with them in the clinic. I review their scans with them. I review their pathology or molecular results, and I make recommendations to them. So these are legal, they are billable, so that the physician and the institution does get reimbursed. It's covered again by Medicare or insurers. The only thing I can't do is a physical exam. I did a video exam on a patient last week, and the patient had a complaint, and I asked the patient's son to take a look in her mouth. And I said, "What do you see?" And he told me. And I said, "I think I know why she's not eating and why she's losing weight." So, this is, just a little aside, but you cannot examine the patient, but sometimes you can ask them in ways, or you can do things to help figure out what's going on. I'm really a fan of these video visits, and I think patients actually like them very well. You can imagine in this time of COVID, but also, let's say COVID wasn't with us. Many of my patients live 100 miles away or 200 miles away, or some of my patients fly in to see me. If it's a routine visit, so not the first visit necessarily or whatever, and I can do that as a video visit, it's fantastic. It really saves everyone time and effort and money. So video visits are one thing that's been done, and I'll come back to this maybe in a few minutes about how this applies to clinical trials. Also, our ability to get the patient's laboratory and scans near where they live, I've been doing that all along. But for some institutions, they said, oh no, you have to come to us and get your scan at our place. Well, that's better probably because you know those radiologists, you can call them up, go over the films, but I'm saying it's not mandatory. And then lastly, mobile phlebotomy. So having the ability to send someone to the patient's home who can draw their blood, take it to the laboratory, have it run without the patient coming in, minimizes the exposure of that patient to potential for COVID. We're now doing a lot of molecular testing. You ask about when would we use blood to do a molecular profile instead of using a biopsy. One of the companies from the Bay Area, Guardant Health, is very, very good about having a mobile phlebotomy system throughout the country. And that helped me a week ago when we had a patient that could not come in. And we were able to send a phlebotomist out to obtain the specimen. And a week later, I had the result.
So, assuming you have a telehealth appointment with one of your patients to go over the results of their biomarker testing, their comprehensive testing, really whether it was through a blood-based biopsy or a solid tumor, what does a conversation like that look like? Is it more challenging? Should the patients have their patient-friendly report in front of them while you? I'm just curious because I know those are really hard for patients to understand in person, let alone over video.
Right. Well, let's just take Guardant as an example. Foundation medicine blood is very similar.
Mm-hmm.
When I view a patient's report, I can check a box that means that it's been automatically given to the patient, it's sent to them, which
Mm-hmm.
I always do. So I like for that to have the information when they see me in person. But it's more important that they have it in front of them when we do a video visit. Way I can see, look down, on page 2, this is the explanation for what this mutation does. So yes, it's a little different, but I think it's not more difficult. It's just different than face to face.
But I think it might even be an example to your earlier point of how we will be able to use telehealth or telemedicine, whichever you want to call it, post virus crisis, right? In situations like this might be a good example of rather than the patient having to travel in, particularly if they're 100 or 200 miles away, you can have this telehealth visit to go over results such as, the biomarker testing.
Yes, I don't think these things are going to go away.
Which is good news for a lot of people who will have access to folks like you and others that they wouldn't otherwise have access to. And I know, there's potentially some licensure issues that need to be kind of weeded out or figured out for some physicians anyway to be able to practice, across state lines or out of states that they are licensed in. But I think this is really pointing us in the right direction to make some of those modifications and changes. Well, you talked a little bit about the clinical trials that are going on at UC Davis. How have they or have they not had to adapt during this time? Because I know a lot of areas around the country, and again, dependent on where you are, have had to close down and or stop some of the research and clinical trials that they're doing due to the virus.
Oncology is probably the most engaged in clinical trials of any specialty. And it's only through clinical trials that we find better therapies, new therapies, ways to handle these situations when the cancer becomes resistant. And these days, it doesn't matter whether the trial is a phase 3 trial or a phase 1 trial. It is quite likely to be beneficial to that patient. So how do we do that in the time of COVID? Well, if you're so overwhelmed with patients in the ICU, one New York hospital last week said they had 500 patients in their hospital with COVID associated problems. It's very difficult for them to say, we're going to go ahead and do clinical trials just like we always did. Their clinical research associates, the people that do the work for the clinical trials, often have been taken off those duties and applied to COVID testing, or they've been even declared non-essential, not at UC Davis, but some other places. So it's complicated. At UC Davis, we've been very fortunate in that we have not had to close any trials, and we have continued to accrue just the way we've always done. But both the National Cancer Institute and the FDA have made it easier. One of those things is allowing video visits. If you're a patient and you're listening to this, you'll know that on a clinical trial, for your safety, we have to do closer monitoring, maybe more frequent visits. The FDA and the NCI, the National Cancer Institute, have said, Dan, this is an extraordinary situation. We will allow video visits if it's a routine visit, because that allows the patient to continue to get a clinical trial or maybe to go on a clinical trial. If we required those face-to-face visits, it wouldn't happen. Even video consenting. So again, if you're a patient on this YouTube now, you know that you had to go through an informed consent process and physically sign an informed consent to allow you to go on a clinical trial. We can now do that by video consenting, where someone, the physician, the CRC, is on the line with you, talking to you, maybe Zoom face to face, and going over the document with you. You have either an electronic or a hard copy, which has been provided to you ahead of time. You provide an electronic signature. That's so important. Many patients said, this trial, I know it's the right thing for me to do. I don't want to have to come in or maybe come 200 miles just to sign a form. So now we don't have to do that. And the central IRB for the National Cancer Institute has also authorized this. Now, if it's an industry-sponsored trial by one of the companies that makes new cancer drugs, some of them are allowing these things. Some of them say no. And some of them have shut down the trials in midstream. They say, we don't feel it's safe to accrue more patients. I think that depends on the situation. Again, in California, especially Northern California, I think we're fortunate in that we're able to do clinical trials with some modifications and continue to offer them to patients.
I really wish we heard more about these positive things on the news, right? Like, especially when it comes to sheltering in place and people getting antsy. And, I remember early on when the governor put the shelter in place and order back in towards mid-March. We thought it was going to be a couple of weeks, so nobody really hummed and hawed about it. But now that we're several weeks in, like I said, and the people are getting antsy, I don't think they're realizing that this was the point, right? Because they're like, oh, here we did all this and we sheltered in place, and then nothing really happened. Like, life went on for patients, per your example, in the clinical trial space. Well, the point was for nothing to happen. That was the whole point of putting all these precautions into place. And also, P.S., it's allowed patients who are dependent on this type of care, at least in this area, to still be able to receive it. And I wish we talked about that more.
These sort of precautions are why we have a flattening curve. They are the reason. This is just like when somebody says, well, why should I be worried about patients who get cancer or donate to cancer research? I don't have it. Well, I can tell you, having one of your family members or friends have a serious illness changes you. There is no way that you take these things lightly. You cannot conceive of people who would not think about their fellow man, their parents, their grandparent, the guy next door, and say that I'm going to do whatever I can to keep them safe.
I do want to talk a little bit about how you're using telemedicine in the second opinion arena. In other words, how the physicians prepare for that appointment and how the patients should potentially prepare for that appointment, using the Care Everywhere example, if you will.
Right. Well, some people who are tuned in may not know what Care Everywhere is, so maybe I'll start with that. This is an innovation that has been in place for maybe 3 or 4 years in some areas, in which all the hospital systems, and this is not just in the Bay Area, this is throughout the United States, can be linked, if they agree, with a program called Care Everywhere, so that the records, the laboratory tests, the scans, the visit notes, the infusion center notes, can be viewed by somebody else who sees that patient in real time. So, up until recently, we would have to have records sent to us, FedEx to us, fax to us, so that, for example, when I saw a patient, I could see what the primary care doctor or the primary oncologist had said in their note. I could see the results of the molecular testing and so forth. Now, when I see a patient, and this would be face to face or video visit, I can go into our Epic system, our electronic medical record, and look under Stanford and click on it and pull up the notes from one of the oncologists there or the scan report. So, for a patient who is going to get a video visit, let's say a second opinion, it's important for them to make sure that the oncologist who's going to see them in a video visit has the information that they need, and preferably ahead of time. I used to tell the patients, copy everything and bring hard copies to me, because if it doesn't get sent ahead of time, I will have it. These days, with Care Everywhere, I can see it all. And again, most institutions are part of this. The worst thing is to undergo a face to face visit or a video visit, and the person giving a second opinion says, I don't have the results of this test or the results of this scan. We're going to have to follow up so that I can look over that information. It's once again making sure that they have that needed information, what's essential to see. And with Care Everywhere, that's very easy these days in most cases.
You know, there's no playbook for recovery. And I use the word recovery loosely, but I think it's valid on how you see everything we've talked about in lung cancer, from screenings, diagnosis, and treatments, moving back towards normal. You've touched on a little bit about how it'll probably be some combination of physical versus virtual visits. How do you see that playbook sort of being written?
Well, no one knows the answer, obviously, but I do think that COVID is not going away. I think it's new and it is different. Influenza would be a much worse disease if we did not have vaccines, and that if we didn't have most people getting the vaccine. If we develop a vaccine for this coronavirus in a reasonable amount of time, and if it works, then we will be in a different situation. On the other hand, if it's difficult to develop an effective vaccine, then we could be in the same situation we're in now for years to come. So it depends on what happens. I don't know if I will ever shake anybody's hand again. My elbows are getting very good at greeting. So our meetings, our medical meetings, some of you who are on this YouTube know what the term AACR means, or ASCO, American Society of Clinical Oncology. It's coming up at the end of this month, and it is going to be virtual, no face to face. This is the biggest cancer meeting in the world, one of the most important. So that requires also a different skill set for the oncologist, because there are certain things you want to see or hear. It's all virtual now. The same thing, AACR just had their meeting a couple of weeks ago, totally virtual. Their typical attendance, I think, is around 25 or 30,000 people. They had 60,000 people sign up for the virtual meeting. So the good news is that oncologists and other doctors, surgeons, radiation doctors, that we're continuing to learn about new information and get new information, but it's in different ways. So I think we will be doing video visits. We'll be doing a lot of things differently for the long run, regardless of whether COVID comes or goes.
I think it's taking a while for people to get used to some of these adaptations, but I think they're happening, and they're happening in positive ways. And I'm with you on the handshaking. I don't know that a lot of people are going to feel comfortable shaking hands again. And Dr. Gandara, I'll leave it the last minute for you to say your goodbyes and some final words.
Okay, thanks, Danielle. Pleasure to be with all of you today. I said that our ASCO meeting was coming up at the end of the month. There are several major advances in lung cancer, and maybe we'll talk about them at a living room at some time in the future.
Absolutely. Absolutely. Thank you, Dr. Gandara. Enjoy the rest of your Tuesday, and we'll talk soon.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.